all this noise? What is going on? All right, let's see what's going on. I gotta go out to the practice today. I have a bunch of patients and whoa, look at all of this. How am I going to be able to get to the office? I forgot today is the Patriots Parade. Oh well, today is definitely a special day. That's not for any specific reason at the office, but rather because a couple of days ago, right here at the Super Bowl, the Patriots won the Super Bowl, and as a result, here we have now a parade going on for the Patriots later on today. It's actually going to pass right by my office and right by the operatory. I'll try to catch a little bit of that for you, maybe discussing one of the cases for you. It's going to be impossible getting to the office. It's a Freemasons building. I found a little side street that is open, so maybe I can just make it to the office now finally. The only way to get by is by crossing the train platform. Well, I can't believe that I actually made it all in one piece. Fortunately, I'm sweaty as hell as I've been kind of running in this crowd. God, what a day. Crazy day. All right, folks, as you can see, the parade is over. People are dispersing. Of course, we ended up seeing the parade while we had a patient. I actually had a surgical patient. I figured it'd be a great time to just share with you this case. It's not a very special case, but perhaps in the occasion of having the Patriots parade going on during the treatment, I figured I'll just share with you this particular case, which was the case of an anterior tooth number 8, that required apicoectomy. There was a tooth that had a previous root canal. It was an old root canal apparently, and recently had the restorative dentist that placed a post and core and a crown, and all of a sudden the patient developed swelling and discomfort and pain, and you can see from the radiograph that there is a periapical lesion. Of course, when we take the CT, all of a sudden it shows how large this lesion is, and it's actually extending all the way to the palate. Usually when you see lesions of this size extending to the palate, that I could in fact palpate on the palatal side. The question with the size is whether this thing is a true cyst or not. And what we're going to do in this particular case was the decision of whether we should do apicoectomy or retreatment. In a case like this, given the fact that the root canal was old prior to placement of the post and core and the crown, it's always preferable to retreat first. But this patient was adamant, having gone just recently through the post and core and the crown, not to redo the post and core and the crown for financial reasons. So understanding that apicoectomy would be a compromise, we proceeded to do an apico in this case. And using the CT, I was kind of prepared for the size of lesion I was going to face on the lingual side. We went in there, essentially, I do a bilateral infraorbital block, and I raised, and plus a buccal infiltration, and I raised the flap with a submarginal incision, exposed the area. There was no lesion on the buccal side, the lesion was on the lingual side, so we had to actually get access to the apex and do the apicoectomy, and found some type of a ribond type of filling material in this tooth. It was not something I'd seen before. It wasn't just pure gutta percha material, it seemed to be like ribond material. Anyway, I ended up creating a very long and deep retro preparation using the ultrasonic tip on the Forza V3, and almost reached the post on the other end. I could see also through the cavity the large, huge cystic lesion that was present on the other side. It was in fact a big cavity. There was no pus in it. It was an empty, large cavity, and I took a little bit of biopsy to send out today to check out and find out if it was actually a true cyst or not. I assumed that it was because it was a very well lined cavity. So at this point, what I did is after the preparation, I used the LIT technique, which is a technique I've described back in 2008. It's a technique that really facilitates the filling of these types of retrofills in a very efficient manner. So in this case, I used the high flow in a syringe that I bent to the length of the preparation, and then I injected the high flow all the way up to the brim of the preparation, and then I placed the putty, just the ball of the putty. It doesn't need to be in the shape of a cone or anything. The whole purpose of the putty, fast set at this point, is to just protect the high flow sealer, or you could use RRM, syringeable, from washing out. And in a technique like this, it's very important not to have a lot of debris, as you can see, because otherwise you could fall right into the preparation. So using very little putty, just kind of close up the top, and I use the micro brush to clean any of the excess and the flash from around the area and clean up the preparation. And you can see that the final result is the sealer, the high flow at the bottom, and the putty up on the top, protecting it for the set. Now, here's the question for you guys. In this case, I didn't quite go in there and scrape the whole lesion out. And the reason for that is it requires extensive paddle anesthesia as well. And this lesion was so large, there was no way I could have, in fact, curetted everything out. Well, how many of you guys think that this would be a factor if it ends up being a true cyst? And how many think that just the fact that we've enucleated it potentially and also gain access to it, and afterwards it's going to fill up with blood, and it's going to, the inflammation will hopefully resolve it? Or will this be a problem that's not going to resolve and would have required for sure some type of a paddle membrane or a graft material? I did not graft or place a membrane on it because the access was very, very minimal, and I just addressed the source. I did explain to the patient that if it doesn't quite heal in the follow-up, or it doesn't begin to heal in the follow-ups, that there might be some additional procedures that might be needed. But in general, if you would think that if the source is addressed, that the lesion should heal. Now, whether there is going to be some scarring or not, we'll have to see. But I wasn't ready at this point to have an extensive surgery on the palate, to raise the palate that far up, potentially cause incisive nerve damage and things like that, in order to merely membrane the site. Anyway, this was the case I wanted to share with you, and I hope this was helpful to you. Just remember, apicoectomy has a great success rate if you choose the right cases and, of course, use the proper technique and address the source, which is the bacteria inside the root completely, and provide a good apical seal. All of the questions about the grafting and so on in apicoectomy has to do with the amount of walls you have left. This was a questionable case, so I figured it'd be a good one to share and maybe generate some conversation about your opinion as to what else should have been done in this particular case, where a minimally invasive procedure was done to do an apicoectomy to address the source of that lesion. So write down, comment below what you think should have been done, or if I did things differently than you would have, and I'll see you in the next video.